So we come back and take a look at this. Well, how can we help this guy for these final two conditions? Let's put an anterior midline incisal stop here. And by doing so, you now suppress the clenching intensity down to about 30%. The guy's not going off the map anymore. As he moves excursively, now you've avoided that canine. So that particular patient, that worked great for him. And he goes, I came to you because I needed an NTI. I go, no, you don't. I put a bump on your splint and you haven't done anything weird since then. You're fine. I don't care what this looks like. My goal was to minimize muscle contraction intensity and minimize joint strain and load. Those are the only two rules of parafunctional control. All right, how can you screw it up? You got to be able to screw it up. That's what the course is all about. I'd much rather if you not do anything or do it right and not screw it up. How do you screw it up? So let's say you've made this lower NTI device. The number one error is excessive vertical dimension of occlusion. Too much vertical. There's the two rules. You're taking a look at this thing and you go, you know what? I see a palatal cusp and a distal buccal cusp. They're really close in there. And I know you're going to go side to side and they're going to get really, really close. I need to get them farther apart. Because that bugs me. I expect this condition to find that and to make me look bad. So, well, I don't like to, sometimes I will never touch a tooth. I can treat a patient while never adjusting a tooth. I will just increase the vertical a little bit right here, and sure enough, bite really hard, and I didn't increase vertical too much because they're squeezing, it doesn't hurt them. Awesome. Well, give the parafunction a couple of nights to figure out how to make you look bad. So what if you didn't notice that you made this nice and parallel, because that's the way we always like to make things, parallel to an occlusal plane, and this patient decides to protrude on you. Now you've got excessive vertical dimension, excessive condylar rotation in protrusion. On the device you just thought you nailed by avoiding that posterior contact, and they bit on it really, really hard, load test, worked great. Now they feel worse. You go, I don't know, man, these NTIs are just kind of weird. I don't like them. That's what you got to do. You have to reduce the vertical dimension, and you got to slope the distal side of that discluding element from there to there. And when I'll see a patient that has got an NTI device and it's not helping them, they come to see me, tell me what your problem is, blah, blah, put it in, go forward as far as you can, and squeeze. I go, I get after that thing. I will reduce that way down, and it's a night and day difference to them. So now you've acknowledged that problem, and now the patient goes back into their retruded clench, and they go, oh, darn it. Those things are super close, and sure enough, they move excursively, and you can see the tip of the distal buccal cusp and the tip of the palatal cusp, they sort of touch each other. And you can extrapolate, if they're barely glancing each other during the day, they'll hit them at night and squeeze like crazy. And that is when I do my occlusal adjusting. If they can wear an NTI device and find a posterior contact, that football diamond comes out of my hole, boom. I don't mess around. I'm sorry to say, Dr. Melkers, if you're out there, I don't take models, I don't mount them, I don't get out my blue paper and tap, tap, tap. If they can have that thing in their mouth and have a posterior contact, I have never met a palatal cusp that I didn't like. I hate them all. Death to palatal cusps. So that's what I do, even though I showed the distal buccal.